Professor Sana Al-Sokhm, Professor of Medical Oncology and Hematology, University of Jordan. Professor Sana is going to give a lecture on systemic treatment of brain metastases in breast cancer.
Sabah al-Khair. Good morning. Thank you, Mr. Chairman. I'd like to thank Dr. Hisham Al-Ghazali and his colleagues for their excellent effort organizing the meeting and for inviting me to discuss this topic in this very interesting meeting. So the outline for my talk would include discussion of the significance, why discuss this topic, the case for systemic therapy, because I know many of you in the audience are very skeptical, and then we'll talk about systemic therapy options and controversial issues. So the incidence of breast cancer-related brain mets has been described in clinical series up to 16%. However, up to 30% in autopsy series. So clinically evident disease is probably much more less than what's there silent clinically. Keep this in mind, please. And lately up to 50% in some subtypes. It can be anywhere. Fortunately, much less involving the whole leptomeninges, and even can be seen at diagnosis. So what are the risk factors to develop this disease? In this retrospective series of 30 years of the Cancer Surveillance Registry of Detroit, they identified young age as a risk factor similar to other series, and this adds to the significance of the problem in our region, since at least 50% of our patients are younger than age 49, and actually 1/3 are younger than age 45. So we are going to face a lot of these patients probably in the near future, especially with improved survival of patients with metastatic breast cancer, since advanced stage is another risk factor. However, keep in mind that can be seen even with early stages. And finally, biologic subtypes. The estrogen receptor negativity, HER2 receptor positivity, and triple-negative breast cancers are especially at increased risk to develop brain metastases. Retrospective series identified a high incidence, up to 50% of brain mets in patients with metastatic breast cancer treated with trastuzumab. It was initially thought to be driven by treatment. However, lately we understood it's the presence of the HER2 receptor. This is a mouse model of HER2 receptor positive cell line developing brain mets. The higher the density of the HER2 receptor expression was, the larger the size of the brain mets in 2 cell lines. Even in early breast cancer, in the series antedating the use of trastuzumab, there is a higher incidence of brain metastases. And after the use of trastuzumab, the incidence of brain mets actually was higher in the trastuzumab arm as compared to the control arm initially. However, with more follow-up, the incidence was more or less the same, speaking for the fact that efficacious treatment only delays the onset of brain mets. In the case of triple-negative breast cancer, the incidence up to 50% in patients with advanced stage disease. And even worse, it involves the leptomeninges, so it's more disseminated disease rather than just brain mets. And interestingly enough, in triple-negative breast cancer, it occurs in the setting of systemic progression. Rather than the case of HER2-positive breast cancer, brain mets occur in the setting of systemic control 50% of the time at least. Why care about brain mets as opposed to other sites of metastasis? Actually, in this retrospective series, followed for more than 10 years of locally advanced breast cancer, you would see, just looking at the curves, the impact on survival for brain mets is quite dramatic as opposed to the impact of survival of soft tissue or bone metastasis. So brain mets do compromise the outcome of patients with breast cancer significantly. And whenever we treat patients with metastatic breast cancer, we always keep in mind this balance between tumor control and toxicity. However, when considering brain metastasis, this balance becomes even more delicate because we are considering quality of life in terms of not just the usual parameters, but also neurocognition. We treat patients to palliate symptoms, to control paresis or numbness or headache and neurological deficit, hoping that we're going to improve quality of life right away by controlling their symptoms. Usually, the classic way has been whole brain radiation therapy, and lately, we became smarter and introduced local interventions, whether stereotactic radiosurgery or surgical excision. I'm not going to talk about local therapy, but just to illustrate 2 points. Adding whole brain radiation therapy to local intervention, whether it's stereotactic radiosurgery or local surgery, surgical excision, does not improve outcome. It has never been shown to improve outcome in terms of overall survival. It does, however, reduce intracranial progression. Keep this in mind. So you're not improving overall survival. Probably you're improving your well-being because you're going to see less intracranial progression. However, no pain, no gain, unfortunately. You're doing this at the expense of actually compromising the neurocognitive function. You are treating your patients to help their quality of life by improving their neurocognition. But what it tends to be that our treatment also has side effects. In this prospective randomized trial, looking at patients with 1 to 3 brain mets from different primaries, inclusive of breast cancer, what they found is that at 4 months, and the study has to be stopped early, the decline in neurocognitive function in terms of verbal learning ability, in terms of total recall or memory, was dramatic among patients given whole brain radiation therapy. So our treatment actually improves one side and yet does affect another silent or not actually quite clinically evident side. However, it's quite evident for the patient, maybe not for us as clinicians. That leads us to another goal when we're treating our patients. We need to improve overall survival. That would definitely be achieved not only by local intervention, but also by extracranial control. So you do need systemic treatment. And in fact, you would think a patient developed brain mets. What's the point of giving more treatment to control systemic disease? However, from retrospective data, we have learned that patients who develop brain mets while having systemic control of their disease fare much better as opposed to those who have systemic progression. In this retrospective series of more than 120 patients, those patients with brain mets with systemic control of their disease had survival which is like 5 times longer than those who had systemic progression independent of the biologic subtype. And in this retrospective series of more than 420 patients, if you look at biologic subtype, in each single biologic subtype, adding systemic therapy did improve the outcome. Actually, the median survival for all patients was 3 months only with whole brain radiation therapy, as opposed to 10 months overall. If you look at subtype-specific outcome, the least improvement was seen with the triple-negative breast cancer patients, speaking for the fact that we are not still yet that successful treating the systemic disease, let alone the brain metastasis. However, if you look at luminal A patients, patients with high expression of estrogen receptor, there is improvement when you add systemic treatment, being hormonal or chemotherapy. You would expect it to be more. However, brain metastasis in the setting of ER-positive tumor are actually the least common. And when they develop later in the course of the disease. So patients are already in the endocrine refractory state. So you do not expect a lot of response anyways of the tumor. However, just to illustrate the activity of hormonal treatment in brain metastasis, 3 case reports of complete remission of brain metastasis in response to tamoxifen has been described. But they had been in patients who presented upfront with brain metastasis. Let's look at the HER2-positive subset and the luminal B subset. Again, a significant improvement. So we do need systemic therapy to control extracranial disease, maybe upfront to improve efficacy while reducing the impact on neurocognitive function and progression after local intervention. How can we use systemic therapy when there is the legend of the blood-brain barrier? How come systemic therapy works? The blood-brain barrier is a tight junction, as you all know, of endothelial cells of the thought processes of the astrocytes. It does not allow agents to cross the blood to the brain. However, adding to the complexity of the problem, it does have an active efflux mechanism. It pumps actually agents from the brain to the blood, including the P-glycoprotein and the multi-drug resistance protein. Adding to the complexity also, it is disrupted in the case of brain metastasis to form what's called the blood tumor barrier. And that is further disrupted if you give radiation therapy, and we do not know how. We know that the permeability does change, but we do not know how much. And another factor we always forget to mention, the drug itself has different properties that could allow or help diffusion across the blood-brain barrier. Taking all these factors together, what can we make of them? We think that we understood a lot of the basic science of the blood-tumor barrier. However, it's still actually the most we understood came from clinical observations. It took a while for us to understand. If you look at the chemistry of the drugs and their ability based on their lipophilic properties to cross the blood-brain barrier, all the commonly used chemotherapeutic agents are not supposed to have the ability to cross the blood-brain barrier or induce any response, all of them. However, all of them have been described to be active, at least in case reports or retrospective series. So how come? Lately, we became smarter to evaluate the experience from the 60s. Even as early as the 60s, activity of chemotherapeutic agents have been described in brain mets. So this is a mouse model of HER2-positive breast cancer with brain mets. And as you can see, radio-labeled paclitaxel was injected and measured in the brain metastasis. You would notice here heterogeneous uptake of the radio-labeled paclitaxel in the brain metastasis. It's not the same. This is a single metastatic lesion, and the uptake is not the same in all parts of the lesion. And this is another lesion, and the uptake is different. So the permeability of the metastatic lesions are different. And what's even more interesting, definitely the concentration in all the brain metastases was higher than what you would see in the normal brain. And if you compare the concentration at different time points in the brain metastasis to that of the normal brain, and to that in different viscera, you would notice actually there is a significant concentration of that drug in the brain metastasis. The problem is that it's not homogeneous, but it's definitely there, despite the fact that chemistry tells us it's not supposed to be there. So penetration across an intact blood-brain barrier is probably not necessary for CNS activity. It's a multifactorial issue. These are all the case reports or case series describing activity of chemotherapy in brain metastasis. And as you can see, the response rate ranges from 25 to 50%, or even 60%, particularly with the old regimens, the CAF and the CMF regimens. Interestingly enough, not so much with the new regimens, particularly the temozolomide, known to be actually able to cross the blood-brain barrier. These are prospective studies looking at the activity of chemotherapy in brain metastasis. And as you can see, the activity of temozolomide is very modest. What does that tell us? Response is not only dependent on the ability of the drug to cross the blood-brain barrier, it has to be active against the tumor cells. So we talked about chemotherapy. How about biologic therapy? Again, the clinical observations had been very important. We learned from retrospective observations that patients who continue on trastuzumab after brain metastasis, independent of the number of the brain mets, survive better. And in fact, in this Korean retrospective series, the improvement in overall survival for patients treated with trastuzumab, if they were HER2 positive, was quite remarkable, about 3 times as compared to those who did not get any treatment. As you can see here, quite remarkable difference. But trastuzumab is a large molecule. It's not supposed to cross the blood-brain barrier. So how come? Could this be just related to extracranial disease control? Let me tell you that lately, trastuzumab has actually been demonstrated in the brain metastasis of mouse models. We do not know how. It's not supposed to be there. But actually, it's been described lately. However, these observations have been made 10 years ago. Supposedly, the small tyrosine kinase inhibitors are able to cross the blood-tumor barrier better. And actually, the initial observation came from the study looking at patients progressing on trastuzumab randomized to capecitabine versus a combination of the tyrosine kinase inhibitor, lapatinib, plus capecitabine. And they noticed the number of patients developing CNS mets as first site of relapse was much less on the combination arm. So that led to a phase 2 study looking at lapatinib by itself to treat brain mets with extension arm for the combination. We learned from that study that lapatinib was successful reducing the size of brain mets, however, at modest level. Only 10% could achieve a 50% reduction. Keep in mind, the 50% reduction, it's not RECIST criteria. They're using the volume of brain mets to assess response, and a lot of studies have looked into the best way to evaluate response. What's happening? Anyways, can we get going, please? It's not closing. الوقت please لأني أنا مش مخلصة أشياء لسه في السلايد. However, the extension arm was more successful, achieving 50% reduction in the volume, and that did reflect an improvement in progression-free survival, doubling of the progression-free survival whenever you have reduction of 50% in the volume of metastasis. That led to the courageous, actually, this is a very remarkable study looking at upfront treatment of patients with HER2-positive breast cancer progressing with brain mets to be treated on a combination arm. And it was successful to delay the need for radiation therapy by 8 months, so actually delaying the decline in neurocognitive function by 8 months, improving progression-free survival to about 6 months, and overall survival that is reasonable. And only lately we learned that definitely lapatinib and capecitabine do get to the brain metastasis. This is a study looking at 1250 milligram capecitabine given to a patient 2 to 3 hours prior to surgical resection of brain mets, demonstrating that you can get a concentration of 5-fluorouracil 5 times that in the serum if you give the patient capecitabine at least at the usual dose. And similar results were seen for patients given lapatinib, particularly if they were given the drug for a few days. As you can see, 10 times the ratio of the concentration in the brain compared to the serum. That led to the cerebral study, trying to reduce or prevent brain metastasis, randomizing patients with HER2-positive breast cancer progressing on trastuzumab to either continue on a combination of trastuzumab with capecitabine or lapatinib and capecitabine, hoping to reduce the incidence of brain mets in these patients. However, they screened out the high-risk patients. 20% were excluded because they were found to have silent brain mets, probably reducing the power of the study to meet its primary endpoint. The number of events were anyways very small. Numerically, it was in favor of the lapatinib capecitabine. However, that was not statistically significant. Again, the time to CNS progression was in favor of the lapatinib capecitabine, not statistically significant. So, what does that tell us? Is lapatinib active? I go back to the retrospective series, all of them describing improved overall survival for patients with brain mets if they are treated with lapatinib in addition to trastuzumab and chemotherapy, at least doubling in the overall survival, as you can see here. Another series describing 12-month survival versus 19 months, and the best 280 patients, a survival of 10 months with trastuzumab chemotherapy, 26 months with a combination of trastuzumab, lapatinib, and chemotherapy, and only 6 months of chemotherapy by itself. So lapatinib is definitely active. How about the new agent, pertuzumab? The famous Cleopatra trial improved overall survival by 15 months. However, it only succeeded in delaying the onset of brain metastasis without impact on overall survival. So what does that tell us? Can we prevent brain metastasis with effective systemic therapy? The question takes us to the question, when does seeding occurs? From the adjuvant trials, we learned that CNS as first event is actually higher in the trastuzumab treated arm. The cumulative incidence, however, is the same. So treatment is only delaying the onset, speaking for a sanctuary effect. The tumor cells are already there and you need effective treatment. The Cleopatra trial taught us that if you use effective systemic therapy, you delay the onset of brain mets. You do not impact the number of brain mets. So speaking for a continuous seeding effect. So seeding of the tumor occurs over time, and prior drug exposure would be expected to affect sensitivity. So I do not think we can prevent them unless we can prevent the disease to start with. Adding to the complexity of the problem, genetic signature of the primary tumor dictates the time when that tumor would get to the brain. So not only the treatment. And in fact, there is a low signature and high risk signature. I just need one more slide of my slides, please. So it's not only the treatment that dictates when your patient would have brain mets. So should we screen for asymptomatic patients with brain mets? You could say it does reduce the risk of symptomatic CNS progression. True, but there is no direct evidence that you would benefit your patients. You would say it would increase the likelihood of localized measures, but I have just shared with you the data that actually local measures do compromise the neurocognitive function. You would say it's a good opportunity for clinical trials, but actually screening patients led to the exclusion of those patients from trials, as we have seen in the cerebral study, in addition to the expense. So how about prognosis? Different models have been developed to predict prognosis of patients with brain metastases. All of them actually identified performance status, age, and the genetic subtype as major determinant factors. Younger age is associated with better outcome, and better performance status is associated with better outcome. I chose this one because it's most widely used. The GPA index was developed based on 400 patients from different institutions treated with radiation therapy for brain mets. And as you can see, you can divide your patients into 4 groups. Some with a remarkable overall survival as opposed to dramatic outcome. And those patients are usually the patients with triple-negative breast cancer and poor performance status, probably due to systemic progression also of the disease. Now, novel therapeutic strategies that are on the way to treat brain metastases are many. Quickly, I will share with you the promising cytotoxic therapies. They are exactly what you know in the clinic. This is a conjugated paclitaxel. It's conjugated to bind a receptor present on the brain metastases and even brain tumors. So you would expect a better delivery. And in fact, results are promising in a phase 2 trial, achieving about 75% clinical benefit with 6 months survival of 80%. This is for progressive brain metastases. That's quite remarkable. And even in the HER2 negative subset, more or less similar benefit. In terms of anti-HER2 therapies, many are actually under development, like neratinib and others, but still, so far, the results in the treatment of brain metastases are modest. PI3K pathway inhibitors, the mTOR inhibitors, Afinitor, it's being actually studied without remarkable evidence of activity so far. The VEGF inhibitors are worth mentioning because bevacizumab has been shown to improve progression-free survival in brain tumors. It does reduce brain tumor-associated edema, and it is relatively active in breast cancer. So that led to a phase 2 trial of carbo with bevacizumab plus minus trastuzumab for the treatment of patients with brain metastases progressing after radiation therapy. And they could achieve a reasonable progression-free survival of 3 months up to 6 months when the 3 drugs were given concomitantly rather than sequentially. An overall survival of about 14 months as opposed to 12 months when all 3 drugs were given concomitantly. PARP inhibitors are also being studied, evaluated for the treatment of brain mets. The phase 2 trial of inaperib in combination with irinotecan in triple-negative breast cancer subset is quite promising, despite the fact that inaperib turned to be inhibitor of metabolic activity more than being a PARP inhibitor. However, the results for a triple-negative breast cancer subset with brain metastases are remarkable, considering that overall survival for patients with triple-negative breast cancer are actually more or less similar to what we see in the treatment arm of this phase 2 trial. And to conclude, the incidence of brain metastases is definitely increasing because the survival of our patients with brain mets is improving. Seeding of the tumor to the brain occurs over time. It's a dynamic process. It's not a static process. And we have to take into consideration the tumor sensitivity to the agent we are studying before we actually work on improving its permeability to the blood-brain barrier. Two factors are important: improving delivery of the drugs and finding effective drugs. Thank you for listening.
Thank you, Dr. Sana, for your very informative session. And one last question. Please.
Yes.
Please, go ahead.
First, thank you, Dr. Sana, for this very, very collective and informative lecture. And I was very pleased, as a comment, to have someone upfronting the SRS treatment instead of the whole cranium. Because
Yes.
I was standing at your position 3 years ago, and it was such a very strange thing to say go for stereotactic radiosurgery rather than whole cranial. And after addressing the neurocognitive function delay that occurs after the whole cranial in the past 3 years, with all the cumulative results, we are now going for the stereotactic radiosurgery first. Two fast questions. First, should we go for stereotactic radiosurgery in combination with chemotherapy? Because you have said we can delay the treatment with capecitabine, because I have like 3 or 4 small-scale phase 2 trials. Second, do yourself recommend to go for the older regimens like the metronomic chemotherapy with methotrexate and Induxan, going for the breast cancer metastasis to the brain, because some Korean and Japanese studies have addressing those issues? Thank you.
Thank you. You know, back to the neurocognitive function issue, survival of metastatic breast cancer patients is improving. So I'm not treating a melanoma patient where neurocognitive decline at 4 months is not improvement. So definitely I would use selective stereotactic radiosurgery whenever it's possible. You need a limited number of brain mets, though these days they're actually being more liberal, allowing more than 3 even to be tackled, which is quite reasonable. I definitely would use systemic therapy every time I use local intervention. It's not like I'm canceling whole brain radiation therapy. I'm just delaying, like in the landscape trial. If I could delay it 8 months, that's a huge gain. For a patient who's going to survive 2 years, if I delay neurocognitive decline by another year, that's better. So I would definitely use local intervention and follow with the proper systemic therapy. In terms of what systemic therapy I choose whatever I feel appropriate for the primary tumor. So it's not necessarily being the old regimen or the new regimen. My point is to use a regimen that I believe would be active in this particular patient, whether it's a CMF or CAF or taxane. If the patient has not been given taxane, I'm not going to go back and give CMF or CAF, depending on the patient. So actually, I treat brain mets similar to what I treat systemic visceral disease or metastatic breast cancer in general.
Thank you very much. I would like to thank Professor Sana Sokhan for her valuable presentation. And we will keep the questions till the end. We still have 4